The next speaker is Dr. Sharam Kordasti, who is a senior lecturer in applied cancer immunopathology at King's College Hospital, London and GSTT. He's going to give a talk on immune dysregulation in MDS and organized mess. Over to you, Sharam, to clear the mess.
Thank you very much. Thanks for the chair and for organizers to invite me today to talk about the immune dysregulation. And yes, can we make sense of what we hear about immunology and inflammation in MDS? So this is my disclosure, but none of them are relevant to this talk. What I'm going to talk about is, first of all, answer a few questions. Is MDS an autoinflammatory disease? Is MDS an autoimmune disease? None of them. Do we have an immunometer to rely on? And if there is one, what's the clinical implications of using that? First of all, being a self-declared immunohematologist, I want to make it clear that there is a difference between autoinflammation and autoimmunity. And that is important because sometimes we use these terms interchangeably and it causes issue, misunderstanding, and also difficulty in interpreting the results. When we talk about autoinflammation, we're talking about mainly myeloid-derived inflammation. And if you go to the extreme, the typical example is CAPS syndrome. Whereas when we talk about autoimmunity, it's very much adaptive immune response. And hopefully you can see, yes. So immune dysregulation of autoimmunity very much is adaptive immune and related to T cells and B cells. And the extreme example of that is IPEX syndrome. So when we talk about this, we need to be clear which one we are talking about. And what about the MDS? You heard yesterday talks when we talk about niche that immunogenic inflammation and perhaps immunoaging important and augment the level of pro-inflammation and impaired clearance of apoptotic cells, etc., and NLRP3 importance in sustaining the inflammatory environment. The other aspect that I want to actually address a comment earlier, that do we have any evidence that if you have inflammation or autoimmunity, it causes anything has anything to MDS? Perhaps the biggest study that's done so far was from Karolinska, that they looked at 9,000 MDS AML patients and more than 1,600 MDS patients, and compared to 42,000 age-matched control. And presence of autoimmunity or infection, chronic infection, and inflammation related to chronic inflammation significantly increase the risk of both AML and MDS. So yes, if we have chronic inflammation, the risk increases. But, of course, it's not enough. It's not the only factor. Having inflammation doesn't mean that you get MDS or AML. The other aspect is immunogenic mutation. Of course, somatic mutation, we know how important they are, but from the immunology side of it is whether they can induce what we call neoantigen and elicit immune response against them also is important. And we have shown this before, that presence of neoantigen are also important in elicit immune response in these patients. And DNA repair defect that you have, and it's known. So combination of these, of course, is not single factor. Combination of these put proliferation pressure on stem progenitor cells that if you have a predisposing genetic instability that is very common in older age, then you may contribute to additional somatic mutations and then contribute to pathogenesis of MDS. So if I go back to here, where is MDS sitting here? Most likely MDS sitting somewhere in between, like majority of diseases. So MDS sitting here has some elements of inflammation and some elements of autoimmune disease. And from patient to patient different, although majority of them are here, you have patients that very much toward the autoinflammatory case, like Sweet syndrome, or patients that they have very dominant oligoclonal T cell expansion, they respond to ATG, and they are on the autoimmune side of the story. And on the autoimmunity side of the story, we looked at a large cohort of 1,400 MDS patients in a collaborative work with Moffitt Center that what are the types of autoimmunity which are common in MDS. Other centers also looked at it. There is a controversy whether having autoimmunity is a good thing or bad thing in MDS. You can argue that, but we have shown different results to the other center. But generally, the presence of autoimmunity is known. So if I want to summarize this, perhaps it's very important to remember it is not a single and a one factor answering everything. We have a combination of environmental factor, genomic instability, myeloid-derived inflammation that lead to more apoptotic cells that going to the immune system, fed the immune system, expansion of oligoclonal or more antigen-specific T cells, and the vicious circle of more cell death and more expansion of these cells until you reach the critical point. And if you have the background, subsequent mutations, and then disease progression toward MDS. And this low-grade smoldering inflammation will continue to feed this and continue to expand these cells. What happens in immune system is a reflection of that, and so basically you have cell death, expansion of T cells, not enough immunosuppression to control that. By little, as the disease progresses, you will have expansion of more of immunosuppressive cells that prevent any response against clone, and you have also exhaustion, what we call as immune subversion. But those are not the only factors. There are other factors. This is a collaboration with Arjan van der Lustrecht and Natalie in Netherlands. We have shown that there are distinct population of myeloid cells that express CD141 or thrombomodulin that highly expressed in MDS bone marrow, peripheral blood and bone marrow, and there is a good correlation that you don't see these monocytes in healthy donors. And if you co-culture T cells with these monocytes, you will have distinct population or cluster of cells that are expanding. And if you look what are these cells, you can see that they actually polarize toward IL-4 and IL-10 secreting T cells, less IL-17 or interferon gamma secretion, and more exhausted T cells. So you have other cells that are not present in normal healthy donors, and they can induce immunosuppression as well. But this is not just in MDS. This is a concept that we know, and it's well established in cancer in general, that you have a range of immune response from tolerance to immunity, and therefore patient A versus patient B, they may have a different signature of immune response, and what we call here is called a cancer immune set point. And based on the cancer immune set point, you may respond to different therapies, different intervention, and that's very important. It's not one factor, it's not just one thing. You have external factor and internal factor, they all contribute to have this whole picture. So it's not just one factor, it's not just one cell or one type of response. But one particular cells which are important and play an important role are regulatory T cells. These are T cells that are known for now a few years, and they are extremely important than switching this whole picture. The problem with Tregs, however, is how you define them. It's very arbitrary, and it's very much kind of based on, I think that this is the type 1 or type 2 or subclass 1 or 2, of these cells, and manual gating. 2-3 years ago, we started using a method of mass cytometry or CyTOF to better categorize or better define these Tregs. And we identified a population of Tregs. We call them Treg A and B, just for the sake of have a simple name. And we have noticed that in healthy donors, we have 2 populations of Tregs. But if you look at the autoimmune type of hematology disease, aplastic anemia, based on the ratio of these 2, you can predict whether they're going to respond to ATG or not, or immunosuppression. And these 2 subpopulations very much, if you overlay the classical definition with the non-classical, with the method we did with machine learning, majority of these Treg3 are not Tregs, and you identify these 2 populations. And then we've identified 8 markers that can define these Tregs. You don't need to go to 40 or 30 markers. These 8 markers actually are enough to do that. And then we have shown that presence and ratio of these 2 can predict response to therapy in aplastic anemia. What happens in MDS, it's even more interesting. Generally, in MDS, the dominant population is in this Treg A. Treg A are less suppressive, less proliferative, and they are not that suppressive immediately. But as the disease progresses, you have more of Treg B, which are very much suppressive, very much proliferative, and they can expand very rapidly. And if this is an example of 4 patients that followed up to 5 to 6 years, and depends on the event that when you have excess blast, this ratio changes. And if it resolves, it comes back. Or if you treat with 5-azacitidine, or if you have lenalidomide, you can see that based on the remission, you have this ratio difference. And why that happens? Treg B, they're expressing CD95, which is a fast receptor, and if you culture them with fast ligand, they go through apoptosis. And this can be prevented by adding IL-2 to culture. And when you add IL-2, they phosphorylate BCL2, then they become resistant to apoptosis. And we know that fast ligand is something that in abundance in the bone marrow of patients, especially in the earliest stage of MDS, and that changes this ratio of these Tregs. If you go deeper, you see that these Tregs is not as simple. The study we did with my collaborator Ben Afzali from NIH, we noticed that there is an additional subpopulation that they express CD161, and CD161 known to be Th17 subtype of Tregs. And it was a bit strange for us, and we wanted to see exactly what are these cells. We have noticed they are indeed very distinct population of Tregs. They are very different from the rest of Tregs. The editor of journal didn't like the name A and B, wanted us to use memory and naive Tregs. The issue with that, but anyway, we had to use it. But you have a distinct signature of these particular Tregs. And when you do single-cell RNA-seq, they cluster completely different from the other types of Tregs. And they have their own specific gene expression profile. When you stimulate these Tregs, they secrete a mixture of pro-inflammatory and suppressive cytokines. They secrete IL-10 and they have IL-17, both at protein level and at gene level. Nevertheless, they are very much suppressive. They are suppressive Tregs, but they have pro-inflammatory cytokines, which is very interesting. So the question was, what controls this? What is the mechanism behind these? And what we have noticed is that although they have ROR-C, as you expect, highly expressed here, but the master regulator of the whole process is BAC2 gene. And if you don't have BAC2, the ROR-C goes up. The editor asked, well, this is your prediction. Do you have evidence for that? So we had to go and find patients with a very rare disease called BRIDA, that they have BAC2 mutation. And see whether these patients actually, they have CD161 expressing Tregs more. Yes, and they indeed have higher expression of CD161, which basically prove that they are CD161 positive Tregs. Why this is important? Because BAC2 is a very important regulatory gene at differentiating progenitor cells to either macrophages and more myeloid related inflammation, or to lymphoid. And if you don't have BAC2, CEP-BP take over, and you have more of the myeloid-derived inflammation, and which TLR plays a very important role. And I've shown you that TLR actually, we have the overexpression or enrichment of this pathway, and you don't have the lymphoid. Can you use this to see whether a patient responds? This is a work that's done by Michaela Fontenay from France, that they have shown that when you, one of the signatures of response to lenalidomide, for instance, is that BAC2 come back. So if you have BAC2, indirectly you can show that this inflammation gone, and therefore the patient have a better hematopoiesis. So what it highlights is that one factor or one type of cells cannot induce MDS. There is no way that one event leads to MDS, as we all know. So understanding of that needs a more comprehensive study of immune system by using multiple different approaches that are listed here, using more networking computational method. And if we do that, most likely we will have a different types of subtypes of MDS. Most likely we have a group that are dominant by the smoldering inflammation, and in this one, likely that controlling inflammation will help. We may have autoimmune subtype that you may do immunosuppression therapy or Treg-based therapy. Patients that they have dominant immunosuppression and you need to revive this, and maybe vaccination help, that you will hear this afternoon by Arian. And those patients that has nothing to do with the immune system, and you need to find another way of treating them. And I just want to highlight this, the importance of this, because you may have heard a very nice talk from Dr. O'Connell yesterday, and she kindly allowed me to use her slide, that when you do checkpoint inhibitor therapy in MDS, you have a modest response. It's not, you have some response, but it's not what you expect. And how do we identify these patients that they're going to respond without giving toxicity to patients that they don't going to respond? And we do need prediction for this response. If you want to, so to summarize, immune response is as complex as MDS itself, and this switch that happens is a very multifactorial and complex, but important. And Tregs are not only important in the pathogenesis, they can hopefully work as an immunometer for us to see where we are in MDS. And systems immunology and multi-omic approach is what we need to do the proper immune profiling of this patient. And if you want to hear more about this, we have 3 days conference in London in September that experts in the field going to discuss this in more details and what is the new direction in immuno-oncology for patient stratifications. So I would like to thank my team that's done all the work, a lot of this work done by Jess and others in the team, and funders, collaborators, particularly Arjan van der Luster, Uwe Platzbecker, Susan Winter, funding bodies, and last but not least, MDS Foundation for supporting the MDS family. The very first grant I ever received when I was a trainee was a travel grant from MDS Foundation that allowed me to go to MDS meeting Paris, and after that I remain in MDS field. So you need to be careful who you are giving this to. Thank you.
Thanks, Sharon, for that fantastic talk. It's open for questions. We could take one, the want of time.
It wasn't that. I hope it wasn't.
I think you made it too clear, I think so. Yeah, there is.
Jen, about your CD161 Tregs, are they alpha beta or gamma delta T cells?
The alpha beta.
Okay, thank you.
I think if there are no questions, we'll move on to the next talk in the want of time.